Observations that I want to draw to you here, as Marty has suggested, the prevalence of anxiety disorders kind of steadily decline. It kind of increases in midlife. For others, it kind of decreases after age 60. So older adults, there is a lesser percentage of older adults who are clinically anxious. So kind of over here. Also to point out, the top table refers to lifetime, so kind of in your life have you ever had an anxiety disorder? Versus at the bottom is the 12-month prevalence, so in the past 12 months, has this happened to you? And then another point I would want to make is that you would notice that the phobic disorders, so specific phobia and social phobia in both tables have the highest prevalence amongst all the anxiety disorders in older adults. And then I would skip the top table because it only looks at 1 month and is pretty old. And then in the literature, you will always hear about generalized anxiety disorder being the most prevalent anxiety disorder in older adults. But based on what you saw just now in the NCS replication sample, that's actually not true. We saw that phobic disorders are actually the most prevalent in older adults. And so where does this finding come from, that GAD is the most prevalent disorder in older adults? Come from a longitudinal aging study of Amsterdam that Beekman and colleagues looked at. And they, instead of looking at 12-month prevalence rates, they only looked at 6-month prevalence rates, which may kind of explain the greater prevalence of GAD in older adults, and you will see that they actually found a prevalence of 7.3, which is pretty high if you compare to what you saw on the previous slide. So remember, 7.3 for GAD versus 3.6, and a 12-month prevalence rate of actually only 1%. So little things to pay attention to as you read the literature. We also briefly talked about onset age, and so this slide is a little difficult to read. It shows you the distribution of onset age for various anxiety disorders. What I want to bring your attention to is that these disorders all have different kind of onset, typical onsets for them. So what this means is if we look at specific phobia, the percentages on top basically tells you that 10% of the cases have had their onsets by this age that you read down here. Does this make sense? So for someone with social phobia, 50% of the cases have had an onset by age 7. So half of the cases have gotten the disease by age 7. Versus if you look at something like GAD, which is marked by chronic excessive uncontrollable worry, actually 50% of the cases have onset by age 31, which is much later. And I would also bring your attention to GAD, say, what this tells you is, this is the 75th percentile, telling us that there's 25% of cases that would develop GAD after age 47. So the opportunities for an older adult to develop GAD is much higher than, say, for them to develop other types of anxiety disorders. And this kind of helps you think about what may be more biological or familial versus what maybe what you would see more with a geriatric onset or midlife onset. So just a few notes on prevalence figures in terms of anxiety disorders in older adults. It really vary widely by setting. So as you read the literature, that's something to keep in mind. They're higher in elderly who are homebound. Among her nursing home residents, those with medical illnesses or chronic medical conditions, as you can probably think about why. Marty also touched on psychological symptoms that do not necessarily meet diagnostic criteria, but still may be clinically important for us to treat or to diagnose. And in terms of older adults, the prevalence of significant anxiety symptoms, or what we call subsyndromal anxiety, was as high as 13 to 19% in the elderly. So it really is an important issue in the older adult population. And with this, there are clinical and research implications. It tells us that detection of late life anxiety is really challenging, and there is a serious problem of underdiagnosis because older adults just tend to deny or underreport, their negative experiences or emotional distress. So this translates into tons of untreated anxiety in the community. And research-wise, study recruitment is such a big, big challenge and presents a significant barrier to really understanding what late life anxiety is. I'll quickly go through the impacts of late life anxiety. As you can imagine, it's associated with very high levels of psychiatric comorbidity, as you can see here. And compared to just having depression alone, if you have anxiety with depression, people tend to have some worse self-report well-being. They would have greater symptom severity if they have both conditions together, greater impairments. They're slower to respond to medication treatment. They're more likely to drop out of treatment, and they're less likely to remit, to get better. In terms of physical health impacts, a huge amount of research has shown, mostly actually in younger adults, but not necessarily in older adults, that having anxiety is related to increased mortality, worse quality of life, things you can imagine, more functional limitations in older adult, and poorer and kind of a self-perception of your own health, highly, highly comorbid with many, many medical illnesses that I won't go into. And a research area is to really understand what mediates the association between having anxiety and having more medical or worse medical conditions and symptoms in late life. And continuing on with this theme, late life anxiety is also associated with significant social and occupational impairment. Anxious older adults suffer from more role impairment than those who are depressed. An important point is that anxiety tends to present itself in primary care clinics more than any other help-seeking locations or clinics or medical centers. And primary care patients who present with anxiety is a very interesting population. They tend to present with more somatization, so they kind of complain a lot about physical symptoms. They're just generally vague, like I can't sleep well, I wake up a lot, I have these pain that I don't know where it comes from. And they tend to be more chronic, they're significantly distressed, and they tend to spend a lot more time going to the doctors, going to their primary care physician, and extremely high usage of services with poor detection. So high, like lots of time spent in primary care clinics and not really getting the appropriate treatment because their anxiety is not being properly diagnosed and treated is a huge waste of resources because they just keep going to the doctors and getting what pain meds and sleeping meds for their anxiety basically. So some issues in terms of diagnosis. If you do get to interact with older adults and thinking of diagnosing anxiety disorders, something to consider is they may not really present to you as telling you that I'm anxious or I'm freaking out over something. They may just say like I'm concerned, or that may be the right wording, milder wording of asking them. I also like to ask older patients, what stresses you out the most right now? Instead of asking like, are you anxious? And they may just say no. In terms of designing questionnaires or presenting them with questionnaires, double negative items can be really challenging for them to understand. Again, older adults may be less willing and open to discuss emotional distress. So if you're assessing for PTSD, they may not really be open in telling you their combat experience. In terms of research, there is a dire need for norms and psychometric properties of, say, questionnaires that we use with just a general adult population. If we feed them to the older adults, will the norms generalize? If I call someone clinically anxious, a younger adult clinically anxious with a score of, say, over 36, can I use the same metric in older adults? So this is a prime area that needs research. What we also need is screening tools to really enhance the recognition of late life anxiety. So think about your primary care physician who sees, 5 patients in an hour. How do you sneak in another short, brief questionnaire for him to screen for anxiety? This is definitely an area that needs development on. In terms of treatment, psychotherapy is very, very popular because, again, older adults are usually treated by their primary care physicians who like to give out medications. And so there is positive research evidence on the effectiveness of medications in reducing anxiety symptoms in this population.